everyone. My name is Lynn McFadden from Endogastric Solutions, and thank you for joining us this evening for our Consumer Educational TIF Talk. This evening, we have the pleasure of having three of our physicians from Western Wisconsin Health joining us this evening to share their expertise and how they manage reflux patients within their practice. So we're live here at Western Wisconsin Health. And I'll give you each a minute just to take a brief introduction. So Dr. Singh, I'd like to start with you. If you'd like to just tell the audience a little bit about you.
Hi, I'm Reggie Singh. I am a general surgeon here over at Western Wisconsin Health, and certainly been involved with anti-reflux surgery for many years, and in various aspects. We've been adding different solutions to our anti-reflux program, with TIF being one of them. So, and I think we've been finding quite a bit of success with this surgical option, and certainly want to educate the community out there about this procedure.
Wonderful. Thank you, Dr. Singh. We'll move on to you. Dr. Chime, would you like to introduce yourself?
Hi, everyone. I'm Dr. Chime. I'm a board-certified gastroenterologist working here at Western Wisconsin Health in Baldwin, Wisconsin. Originally trained in New York, residency and fellowship, and moved out here 3 years ago. And like Dr. Singh said, we've been collaborating with trying to help manage reflux disease in this part of the country, and it's been an exciting journey.
Wonderful. Thank you and welcome. And next we have Dr. Ade. Would you like to take a minute to introduce yourself as well?
Hi there. I'm Dr. Lacmbouh Ade. I'm a board-certified family medicine doctor, trained in the Fox Valley area. I had a very early interest in reflux management and also like endoscopic procedures. So I have some training in that regard to be able to help patients who were struggling with various conditions, with reflux being one of them. So I'm excited to be a part of this meeting today.
Wonderful. Thank you all and welcome to our talk this evening. We structure these to be highly educational, highly conversational. So without further ado, we'll start kicking it off by just giving folks a general definition. What is GERD exactly?
So GERD stands for gastroesophageal reflux disease. So it is a condition where patients have symptoms due to excessive acid reflux. So gastrointestinal content, like contents from the stomach, sometimes can go up into the chest and cause symptoms ranging from heartburn, as patients will call it, to nausea, to abdominal discomfort. Sometimes patients will present and they tell you they get burning in the chest. And they will tell you it is more prominent after eating certain foods. And typically before they present to come see us in clinic, they have done some dietary eliminations before they actually do present, to be able to see what other interventions could be utilized to help with symptoms overall.
Yes, excellent. Thank you. It's so true. There's such a range of symptoms and how people could be feeling and what they're experiencing. So, the greatest message out there is not to delay getting checked and evaluated to really find out what is causing all those symptoms. Reflux might be at the crux of that. So thank you for that definition. When folks are struggling and having those symptoms, how do they find out if they have GERD? What's involved in the diagnostics?
So just like we had talked about, typically patients are going to come in with reflux type symptoms, and usually they have tried over the counter interventions. Some of them will tell you, I've tried Prilosec, I've tried ranitidine or Pepcid or Pepcid or similar medications, and also they have tried some dietary eliminations before presenting.
Dr. Chime, did you want to add something to that conversation as well?
Yes, so I wanted to add on a little bit on on the presentation is the patients could also have symptoms that are kind of outside the upper GI tract realm, and we call them extraesophageal manifestations of GERD, where some patients might not have heartburn but present with cough, or probably be sent from the ENT because they had a laryngoscope that showed some erythema over the vocal cords, or patients who describe regurgitation of content to the back of their throat. Sometimes acid reflux can actually give patients dental caries or acid taste at the back of the throat, or acid taste in the mouth. So that's one other way you could present besides what Dr. Day talked about regards to heartburn and chest pain and the likes of it. For the diagnostic part of it, it's evolved over time. Historically, we used to depend on presentation to diagnose GERD, but now we're getting a little bit more objective in the way we diagnose this, particularly for the patients who have extraesophageal manifestations. And this is where the pH studies come in. So we used to have the wired pH where the patient goes home with a catheter through their nose for 24 hours. But now we're gravitating more towards the wireless version of what most patients know as the Bravo device, which is a wireless sensor placed in the lower esophagus during endoscopy, and the patient goes home with a recording device. And over a 72 to 96-hour period, you can actually tell objectively how much acid reflux they have. But also more interesting is you have the ability to determine if there's an association between the reflux and the symptoms. So that we can actually tell patients, particularly which symptoms might be due to acid, especially in patients who have those extraesophageal manifestations like cough or ticklish itching at the back of the throat. We can actually help them to determine if this is something that needs another specialist like a pulmonologist or ENT to get addressed, or if this is something that will get addressed with anti-reflux control.
Very importantly, when patients do come in, kind of if they have not had some of these testings, but the first one is we usually rely very heavily on upper endoscopy, where we put a camera down into the esophagus, into the stomach, looking for any inflammation in the esophagus, looking for hiatal hernias, those type of things that might be the underlying cause. Of course, looking for any other issues that might be present. Additionally to the upper endoscopy, sometimes, I'll also add a upper GI or a X-ray test where people will swallow some dye to also help diagnose reflux too. So it's just in terms of the diagnostic workup. Yeah, so.
All right, so just to add on to what Dr. Singh said, there are patients that will come in with an upper endoscopy and have some findings that define GERD. So if I do an endoscopy and patients have evidence of Barrett's esophagus, or have a high-grade esophagitis, which is where there's evidence of burn marks caused by the acid in the lower esophagus, grade C or grade D, those patients might not necessarily need to have a Bravo done. The Bravo usually would help you in patients who have something we call non-erosive disease, where there's no evidence of acid damage. And again, particularly patients who have those extraesophageal manifestations to help you delineate if this is due to reflux or not.
Wonderful. So the diagnostic tests there's your general diagnostic tests, and then there could be others depending on each individual and how they're presenting. So thank you for explaining those tests. That's often an area where patients, might not understand what each test entails and why each test is being ordered. So thank you for that description. Once they have that diagnosis of GERD, how do you each manage those patients in your practice? And Dr. Ade, I'd love to start with you, being that you're family medicine, you probably see a lot of those patients in your practice each day. So what do you do as far as once that patient is diagnosed with reflux? How do you manage those patients? And when do you start thinking about maybe sending them on to a specialist for additional care?
So, I mean, I think it all depends on their degree of disease. So if a patient presents and you put them on a proton pump inhibitor, which is one of the highly utilized medications for management of GERD. If at a low dose, the patient tells you, you know what, I have adequate symptom control. And if they are presenting and they've had an endoscopy from an outside facility and there is no evidence of reflux esophagitis, which is significant inflammation, irritation of the esophagus, or other complications from long-term reflux, be it Barrett's esophagus, which could be a pre-malignant lesion, you feel like for that patient is relatively low profile. So in that situation, you can present options to them and tell them, we can continue to monitor symptoms on this low dose of a proton pump inhibitor. And for some patients, some subset of patients, that is adequate for them. But some patients, no matter what you put them on in terms of medications, they still continue to struggle with symptoms. And in that situation, those are the patients that are going to move on to getting the Bravo studies done, just to see what extent of reflux they have and what interventions could be utilized to help them overall.
Excellent. Because we hear that patients often will stay in that cycle of medication management, and it's often not really helping them. We hear too that reflux is a mechanical condition that often requires intervention. So once you send them off to a specialist or talk to them about procedural intervention after they've exhausted the lifestyle modifications and medications, Dr. Chime, would you like to take it from there? And then once you see those folks from the primary care or family medicine physician, what do you typically do and how do you manage them in your practice?
Yeah, so you touched a little bit on the two key points, which is the lifestyle modifications and then the medications. I always try to make sure that the patients understand what role those play, things like avoiding trigger foods, try not to lay down for 3 hours after eating, particularly, dinner and stuff. I tell patients try and lay down on the left side because it's more protective for reflux. And medications, I kind of go over with them what strength they're on, the timing they're taking it. Some patients might come to you saying that they're taking high dose of omeprazole and it ends up they're taking it at bedtime when it's better in the morning. And just switching around some of those lifestyle medications might help. But there are some patients that would need the next stage. Most patients come to me when either they've been on these medications for several years and they want to get off it, or the primary care has been escalating the medications and patients are still symptomatic.
Sure.
And one of the talks that I have with them is that there is something called non-acid reflux, right? So all we're doing with the medications is trying to control the acidic components. But if patients are having bile reflux or reflux of digestive pepsin, those patients, no matter how much escalation you have with the omeprazole, would still be symptomatic. And those are the patients I start to let them know that, because this is could be a structural disease, particularly if the endoscopy showed a hiatal hernia, if the valve, has a heel grade 2, 3, or 4, regardless of the acid suppression, they might need those structural aspects to be addressed. And that's where the surgical, options, come in. Of which, based on what we're talking today, the TIF procedure is something that I also kind of let them know that this is the new kid on the block and these are what the pros, advantages and all that is, especially patients of mine who come in with trouble swallowing and having reflux at the same time, because over time, chronic reflux could actually cause weakness of the esophageal muscles. And you're worried that if you go ahead to fix those structural reasons for reflux, the dysphagia or difficulty swallowing may get worse. And I think this is where Dr. Singh will probably come in to give us more in-depth information on what the TIF procedure is. But this is one of the benefits that I actually highlight to the patients, and which is also very interesting to me, how TIF makes a difference when it comes to the rest of the anti-reflux surgeries.
Right, excellent. And so we brought up the TIF procedure. We did talk about medication management. We talked about lifestyle modifications. When we talk about procedural interventions, one of those is the TIF procedure. And the TIF procedures, it's transoral incisionless fundoplication, one of the many interventions out there to help treat folks with reflux. Do you want to talk a little bit about how and when you introduce the TIF procedure, and in what patients do you typically start those discussions? I guess at what point I'm asking.
Yeah, so the point I do is usually when I'm sure they've optimized lifestyle changes as much as possible, and also kind of adhering to the medications and taking at the right pace. And then I also try to figure out if there's any component of dysphagia with the patients, because this kind of helps me to pre-select. And during the endoscopies, how much of a hiatal hernia they have, what the valve looks like. So that helps me to determine who would benefit most from the TIF procedure. So at that point, I let the patients know that surgery sometimes for reflux is not really the last option. There are patients who it comes in earlier in the course of treatment and not have you develop the long-term effects of acid reflux like Barrett's or esophagitis before we say, oh, let's go ahead and do surgery. So in those patients who have had chronic reflux and are having some issues with medication management, and I'm convinced that they've optimized lifestyle and also doing the medications the right way, I start to, prime them with that discussion that, at some point you might have to have this surgically corrected.
Absolutely. And Dr. Singh, would you like to talk about then the surgical intervention part in treating these reflux patients?
Sure. So, over the last several years, been doing quite a bit of anti-reflux surgery. When we do see patients, they've usually, number one, have been on quite a bit of medication, and they're failing it either due to ongoing reflux issues or complaining of heartburn, complaining of my biggest issue, patient who has failure of medical therapy is regurgitation, where gastric contents are still coming back up into the esophagus or even up to the back of the throat, because in its form, this is really a mechanical issue, and we can't control that with medications.
Sure.
Very importantly, a lot of times, though, some of these folks have not really maximized their lifestyle changes. So very importantly, when they do meet with me, we kind of go over what they have done with lifestyle modifications, with number one being weight loss. And so with current indications for anti-reflux surgery, people really do have to have a BMI of under 35. Otherwise, really the recommendations are to do bariatric surgery if they're not able to lose weight. So there is a little bit of separation of the type of patients we see right there. Almost all of the patients that I see have some component of a hiatal hernia. And although the TIF is transoral incisionless fundoplication, it's in my mind, it's really has to be combined with a surgical procedure where we have to kind of fix the hiatal hernia. And the hiatal hernia is where the top portion of the stomach is now herniated above the diaphragm, thereby not really allowing the natural valve mechanisms to work properly, and which is causing the reflux. So it's really a combination of fixing the hiatal hernia and then improving what we call the lower esophageal sphincter, which is the valve at the end of the esophagus that keeps things from refluxing or regurgitating back into the esophagus. And there's several different techniques that have been developed. The original one is a Nissen fundoplication. It's still a very commonly used procedure. There's for some folks who don't qualify for a Nissen, a more of a partial wrap where we're surgically improving the valve around the end of the esophagus. Those are also there. There's some other mechanical devices, and then TIF has been around for quite a while. But the incisionless portion initially was tried to repair the valve mechanism by not repairing the hernia. I don't think it's as good of a repair, and I think most people, again, about probably 90+% of people have some type of hiatal hernia component. So surgically, we end up either laparoscopically or at Western Wisconsin, we do a robotic approach where we go transabdominally, so through several small incisions into the abdominal cavity, bring the stomach back down into the abdominal cavity, and then repair the hernia in the diaphragm with stitches, and then we perform the TIF or any other procedure depending on what is best for the patient. We will then improve the structure of the valve so they don't get those the reflux issues.
Excellent. So there's two procedures going on. You're saying approximately 90% of the time with folks who have both reflux and a higher hernia that also needs a repair in order to keep everything intact and structurally sound, if you will.
Exactly.
So thank you for that explanation. Not everyone realizes that a hernia could really exacerbate reflux and those symptoms, and just understanding how that happens is a great baseline for patients to have and understand. Dr. Day or Dr. Chime, is there anything you'd like to add to what Dr. Singh just presented?
So I would say like the subset of patients that have gone through this anti-reflux surgery with at Western Wisconsin Health, like we have a great success story. A lot of the patients are able to eat some of the foods that they could not tolerate before. A lot of them are able to come off their medications they were dependent on before the surgical procedure, and it's a minimally invasive procedure, so you don't get recovery time is not extensive. So patients worry a lot about that, from a pain standpoint, from an economic standpoint. So we try to let patients know it is a minimally invasive procedure that we can do, and we can provide a lot of relief for them. And those medications, just like we talked about earlier, they are with some risk involved. So if patients have to be on long-term medications for control of acid reflux, we normally would recommend vitamin D and calcium, because osteoporosis, bone health, those medications could negatively impact the bones. So in addition to other risk involved. So it is an easy procedure to perform, which could be life-altering for a lot of patients.
That's excellent to hear. Thank you for that feedback. It's always important for patients to hear other patients' stories and how, how they're doing post-procedurally and how their lives have changed. So it's exciting to hear that you're seeing such great outcomes. Dr. Chime, did you have anything to add to that as well? You're all seeing this population quite regularly and seeing them for the TIF procedure and after. What are you hearing?
Correct. So 9 out of every 10 patients are able to get off the acid suppression medication within the first 4 weeks, usually. And in the beginning, I had mentioned that one of the reasons the patients come to me is having been on these medications for 20, 30 years. They're concerned about the risks of side effects or associations, like Dr. Day pointed out, and they want to get off the medication. So one thing they really want to know is, how soon can I get off these medications? And most people can get off with medications in about 4 weeks. There are 10% will probably require a less amount than they did. So if they were doing probably 40 twice a day, they might realize that they're better off with 20s, which again is a significant improvement, because with all these medications, you want to stay on the lowest possible dose. And another thing that the patients also kind of appreciate about the TIF is the ability to belch and throw up. Some patients initial reluctance having anti-reflux procedure where they know someone who had maybe a Nissen or something, and when they get the flu, they can't throw up, they're just going to dry heave. So because this is a 270-degree wrap, there's always that 90-degree that allows you to belch and throw up. And also, like I said, with the dysphagia, is less of a side effects with the TIF. So those are the success stories and the positive reviews that patients have given when it comes to using TIF. Yeah.
Thank you, and thanks for pointing out those potential outcomes to. Every procedure has an outcome. Not all are positive. So thanks for explaining that and shedding some light on what you're hearing in your practice. Dr. Singh, what is recovery like? Can you talk to us a little bit about the post-procedure recovery?
Sure. So I would say probably around 75% of the folks will go home the same day for our procedure. Some people will stay in the hospital overnight, either because of persistent nausea or pain and discomfort that might need to be managed with additional medications, but the vast majority are going home the same day. It is a fairly rigorous post-op course, mainly because of we have a fairly controlled amount of food that folks can eat because of the way the procedure is done. We do ask people to, be on clear liquids for the first week, and then what we call full liquids, and very slowly advance their diet to a more regular diet over a period of 30 days. But nevertheless, they still have to eat smaller meals more frequently to avoid problems with nausea and vomiting in the long run that can possibly affect both the TIF repair or even the hiatal hernia repair.
Sure.
The amount of lifting is certainly very controlled over the first 8 weeks. We really ask people not to do much lifting beyond 20 to 30 pounds. And after that, they can certainly start going back up. But I think in terms of what the average person feels is that usually after the first 7 to 10 days, they're kind of back to most of their normal activities, except for the diet, which, it's very prescribed. Pain is, most people don't need narcotics for more than a day or two, if that, and are managed then well with anti-inflammatories or even just regular Tylenol. They're back to work usually within 7 to 10 days, and driving within a few days. So it's a fairly easy recovery. I think the most difficult part is certainly the diet for about a month.
Yeah, thank you for that. It's like everything else. It's baby steps. You got to give it time to heal, and you got to be gentle on yourself for a little while after. But we talk to a lot of patients who say the diet is quite tolerable. It's just thinking about your food in a different consistency for the first go. So a lot of pureed, a lot of very, liquid consistency. So thank you for that description. And do either of you have anything else you'd like to add to that, to the recovery and what you're seeing in your patients?
Yeah, I do want to mention, the folks that, I usually see them back at 2 weeks and 6 weeks. And we do continue, as Dr. Chime was saying, we do continue the acid suppression for 4 weeks to kind of let the areas where we've operated on heal. But the improvement in regurgitative symptoms is really just night and day. People come and say, I don't have anything coming up. I'm not coughing. I'm sleeping better. I think those are just are really great stories to hear. So we've had really good success with that.
That's excellent. We're so glad to hear that. And it's wonderful to hear your patients happy. They come to you unhappy and go through this journey to find that their lives have changed for the better. So we all love hearing that, especially you. This is your life work. So thank you for sharing that. To close us out this evening, I know we typically, when we talk about reflux and GERD, there's two very prominent national healthcare observances that take place each year. One of them is GERD Awareness Week, and that falls in November, right around Thanksgiving. So to the earlier discussion about diet and foods being something that can exacerbate reflux, we hear wine and chocolate and overindulgence. So it's appropriate that GERD Awareness Week, it reoccurs each year at over the week of Thanksgiving. The other one is Esophageal Cancer Awareness Month. We spoke a little bit about it, but every April, Esophageal Cancer Awareness Month is observed. And I'd love for you to tell folks about the correlation between reflux and potentially progressing into something more serious, and if that could potentially progress into cancer down the road. And give us your thoughts on that.
Sure, I'll chime in at this point. So there are generally two types of cancers you can find in the esophagus, and that's based on what kind of cells they're arising from. So there's the squamous cell and something called the adenocarcinoma. The incidence of adenocarcinoma at this point has overtaken that of squamous, which used to be predominant in the past. And we think it's because of the increasing incidence of reflux. And why do I say that? It's almost universally the adenocarcinoma arises from Barrett's. Now, Barrett's is something you find in the lower esophagus in patients who have had chronic reflux. Now, people hear the word Barrett's, just to go a little bit into what it means. So what I tell my patients is that it's normal cells in an abnormal location. So they're intestinal cells, but now they're found in the esophagus. The reason why the body does that is the intestinal cells are well adapted to cope with the effects of reflux because they always get acid from the stomach. But the problem with that is when cells migrate that way or appear in a different location, the cancer check mechanism does not move with them. So the esophageal cells have a specific cancer check mechanism that keeps the squamous cells in check. But once they switch and become intestinal cells, then there's that increased risk that they could switch to something called dysplasia and then eventually become esophageal cancer. The problem with esophageal cancer is similar to pancreatic cancer. By the time you're symptomatic, it's late. And also there's a lot of blood supply in that area, so spread is usually early. So this is a kind of the cancer where you want to find it when it's a precancerous lesion and not when patients have become symptomatic with weight loss or trouble swallowing and things like that. So one of the things we're trying to do here at Western Wisconsin Health is to build a good Barrett's program. And what that starts with is trying to identify patients who are at risk of Barrett's and then have them do at least a one-time upper endoscopy to find those Barrett cells. Because if they're present, then we become the cancer check mechanism. And by that, I mean that the patients get into a surveillance program where they get an endoscopy every 3 to 5 years. And once we pick up that early sign of dysplasia, then we have to have the Barrett cells eradicated to prevent them from progressing to esophageal cancer. So part of the awareness of esophageal cancer is actually letting patients know that we can actually identify when it's precancerous lesions and then keep an eye on it to make sure that it doesn't progress to esophageal cancer.
Yeah, excellent. Thank you for that. And just encouraging folks, it's just the consistent message is don't delay if you're symptomatic or you're feeling some of the symptoms atypical or typical. See your doctor, get it evaluated and see, what is at the crux and what your treatment plan may entail. But being in your hands and your care is step one. So thank you for that. Dr. Singh, did you have anything to add to that?
Yeah, I mean, I think it's kind of following up with Dr. Chime. If most of the medications, especially the Prilosec, they're over the counter now, have become so common. I think people forget that they really are indicated for a very short course of time, at least if you haven't seen a physician. So if you're self-medicating and self-diagnosing and saying, all right, well, I'm having issues, but if after a period of 4 to 6 weeks, medications have not helped, and you have problems with swallowing and, or even, as Dr. Chime said, weight loss, those are really important symptoms to have looked at, or if you're failing therapy, to have looked at. So sometimes I think we think that just because it's over the counter, we can just continue to take these medications. But if you have not had significant improvement in symptoms over a period of 4 to 6 weeks, then I think it's time to seek help. It doesn't mean that you're going to have surgery, but it does mean you might need further evaluation of what's going on.
Excellent. Dr. Ade, anything to add there too?
Yeah, I feel like being in family medicine, the biggest thing is all about prevention. That's why we encourage patients to get like even colon cancer screening, because you want to take out these polyps before they become cancerous. Also, with regards to the esophageal cancer, especially the adenocarcinoma, if patients have Barrett's, you want to catch it early and treat it, or maybe even best case scenario, prevent them from developing the Barrett's to begin with. So just like Dr. Singh and Dr. Chime have said, symptoms should not be ignored. If patients have symptoms, they should seek help and just try and have a healthcare professional evaluate them to see what the best course of action is going to be in terms of just preventing them from getting cancer. Because when you get to that stage, treatment is usually much more difficult, and for some patients it's not even an option.
Yeah, thank you for that. I think on that note, I think one, I want to thank each of you for your passion and your dedication to collectively treating these reflux patients and the various roles you play in that care pathway. Thank you for being on this evening and sharing your expertise and really diving into this disease with those who join on the segment to listen and learn. So thank you again for being here. If you are in Baldwin, Wisconsin, you can find one of these wonderful physicians if you have reflux and you're looking to get evaluated or go for a consult. These physicians are here in Baldwin, Wisconsin at Western Wisconsin Health. Otherwise,
I do want to kind of just, I think the last a point that, I one of the few places that we collaborate very closely with primary care, GI, and surgery. We all try and work together as a team to make sure that everyone's kind of getting the best care. A lot of times things are very fragmented, but Western Wisconsin has really done a great job in giving us a team approach and giving us all the tools that we need to kind of provide all the both the diagnostic and therapeutic care very locally.
I think that was a great call out, and that care collaboration is significant for patients, and the team that you've developed here is pretty wonderful, and they're in great hands. So thank you for that. Appreciate that.
Thank you.
Thank you.
Thank you.
Oh, you're welcome. If you are here in Baldwin, Wisconsin, again, you can look to Western Wisconsin Health for any of our physicians who are here today. Otherwise, we have a physician finder tool on gerdhelp.com. On that site, there's also a mobile application that you can download. There's instructions there. So if you're struggling, you're trying to learn more, that app is really helpful. So we thank you all for joining. Thank you for tuning in this evening, and we hope you walked away with some additional knowledge. Please share it with your friends and families as well. And please tune in next time. Again, thank you everyone for joining.
Now that I'm 9+ weeks out from surgery, it's pretty surreal that I keep waiting for heartburn to happen. I keep waiting for the GERD symptoms to come back after I start, implementing foods that I can eat again, and it's not happening. I feel very happy. I feel very grateful. I feel solid in knowing that the TIF procedure worked. I've been running again. I can do push-ups. I can bend over and pick something up without acid coming up into my throat. Yeah, I'm serious. I mean, that's where it had gotten. The dry mouth and the dry throat and dry esophagus, it made it really difficult to speak. And I would get a sore throat a lot from sleep. When I would sleep, the acid would come up into my throat and I would wake up with a sore throat and a hoarse voice. Now I wake up, maybe I think about it because I'm conditioned to think that way, but the cool thing now is that if I do have that thought, which is fluttering away each day, but if I do have that thought, I quickly can scan myself and there's no heartburn, and there's no sore throat, and there's no wheezing, and there's no fear about having a cup of coffee I just don't wake up feeling defeated and sad and down. I mean, if somebody is having severe GERD symptoms and they've exhausted all their options, even if they haven't exhausted all their options, if they have severe enough symptoms like the symptoms that I had, I would 100% suggest a TIF procedure, because it's been a complete 180 to the way I feel and for the things that I'm able to do now. So if somebody has severe GERD symptoms, chronic acid reflux, I would 100% recommend the TIF procedure.